Welcome to this Room Now Roundtable on Gout at the 2020 ACR Convergence meeting. I'm Michael Pillinger from NYU Grossman School of Medicine, and I'm pleased to be this year's Gout editor for Room Now. I'm joined today by two really wonderful goutologists and colleagues, and I'm very pleased to introduce them to you. These are Dr. Naomi Schlesinger, who is Chief of Rheumatology at the Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. Hi, Naomi, welcome.
Hi, good afternoon.
And Dr. Robert Keenan from the Florence Rheumatology Center of Articularis Healthcare, who is also Adjunct Associate Professor at Duke University School of Medicine. Hi, Rob.
Hey, thanks for having me. Glad to be here.
So I wish we were together in the same room, but there's lots of interesting things going on at this year's meeting regarding gout and other crystal diseases. So let's chat about a few of those things. Rob, let me talk about, or ask you to talk about imaging a little bit. You know, when we first started hearing about dual energy CT DECT a couple of years ago, it seemed really exotic and almost impossible to get done anywhere anyway. But I'm seeing a lot of abstracts this year that it might be moving into, if not routine use, at least maybe routine research. Is there anything worth noting for our audience about?
Yeah, there were several abstracts this year and a few talks as well about dual energy CT specifically and just imaging and gout in general. And like you said, I think it's not quite standard of care at this point or in routine use, but the more research that comes out, that hopefully kind of will lead the way to a little bit more routine clinical use and also just better diagnostics in general, which, you know, one of the abstracts, well, there's a couple of abstracts I wanted to mention or at least talk about or touch on was as far as the quality of imaging, there's still not quite, I guess, a consensus on what joints you might want to actually image. You know, everybody assumes, okay, the feet, that's a good one. That's a relatively easy one to do. And maybe the knees. And there was a study actually by Sarah Christensen out of Denmark that was probably one of the best talks, best explanations of dual energy CT I've actually ever heard. And what they found was, interestingly enough, that it seems that the patella tendon specifically, as well as the first MT in their mind, in their cohort that they were looking at, was probably the most sensitive and specific areas to look at for imaging and to pick up those monosodium urate crystals and distinguish them from other crystals such as CPPD, for example. So that was one interesting. And then there was another study I thought was pretty interesting as well that kind of contradicted a lot of the studies that are already out there. And that was by Dr. Schaefer out of Germany. And what they showed, it was a little bit of a smaller study, but what they showed was the sensitivity and specificity of dual energy CT compared to ultrasound was not that much better. The sensitivity actually was a lot lower than that of ultrasound, while the specificity was much higher than other reports, or at least it was 100% in their study, which was about 10 to 15 or maybe 20% higher than in other published literature over the last several years, versus ultrasound being around 70, 75%. Now, I know I was supposed to mention the abstract numbers on that. So that abstract number was 1542, and then the Christensen abstract number was, what was that? That was, I want to say 445. That was in some of the talks.
I guess you can remember these things.
So, but I thought they were both interesting studies, and there were a few other studies out there looking at ultrasound versus dual energy CT. And out of there was a group out of Paris and Spain specifically, and I believe it's the Crystal-Isle cohort that they're looking at. And I think Dr. Jazz Singh was involved in this one abstract specifically that looked at dual energy CT versus ultrasound in alone, in combination, or in which is better, basically, and which is a better diagnostic tool. Are they both better together, or is one better than the other specifically? And what they found was that the dual CT was actually better. And what joints they found to probably have the most sensitivity as well as specificity were the knees and the feet, which is similar to what Dr. Christensen found, just not quite as detailed as saying the patella insertions versus and the first MTP. So, I mean, all that's exciting stuff, and hopefully we can, at least in routine clinical care, this becomes a little bit more easy to get or easy to find. But I know that it's still somewhat cost prohibitive, especially compared to ultrasound. Sure. And I think too, as technology improves, and not only with ultrasound, maybe eventually doing your CTs will get cheaper as well. But if I can say one more thing that kind of, as a segue, there was another interesting study I wanted to bring up, and this goes along with comorbidities as well. And I know both of you are in the same camp I'm in about cardiovascular disease and gout going hand in hand and being an independent risk factor for cardiovascular disease. And there was a study here again of that same group out of Spain and France, the Crystal Isle cohort, I'm not sure how they say it, of course, but they, and this was abstract 954. And what they found was they looked at 128 patients. And what interested me was, aside the fact that only 62% of these patients were not on urate lowering therapy, but only 48% or 38% were. But they found that the higher volume of crystal deposition was associated, as well as serum urate levels, were associated with all-cause mortality over history of MI, over BMI, over hypertension, over smoking, over stroke history. All those things did not show overall all-cause mortality as the serum urate levels and the crystal deposition on dual CT did. And what was another interesting point with that study was even though they couldn't figure out, or it wasn't clear what volume had to be there to distinguish those folks from the rest of the group with lower risks, was the dual CT deposition, crystal deposition, was the only predictor of new onset cardiovascular disease or heart attack and diabetes. Here again, weight wasn't associated with it. Other cardiovascular risks weren't associated with it. PAD wasn't associated with it, et cetera. It was interesting findings, and it's just, it was a decent sized cohort, but I think further studies will obviously be needed to kind of, validate those findings, but it's still definitely something to think about.
So I guess, and maybe I'll ask you this, Naomi, quickly. It sounds, Rob, a little bit like what we're learning is how to maybe use this modality. If we're trying to make a diagnosis, there are probably places to look where the sensitivity and specificity is good, and others that aren't. On the other hand, if we're trying to examine a cause of pain that might be gout, it might be a different situation where you might go to a normally less sensitive area. And it might be either, from that last study, a better severity marker, or it might be telling us biologically something completely different. I don't know, Naomi, how do...
I want to add a few things, actually. We, although it's not, we haven't revised this for publication as of yet, but we looked at our cohort of dual CT, and I was actually pretty shocked how few were actually, this is not in a study, this is a real life cohort, how few of my patients that I asked them to have a dual CT had it because the insurance did not approve it. And then, looking at patients, so within the first 3 years, many of them don't have any changes. It doesn't mean that they don't have gout. It just means that they didn't have changes suggestive of gout. I want to add that I saw today a PERS lecture by Dr. Stone, and he talked about temporal arteritis and how it used to be the golden standard was to do biopsy, but maybe now imaging. And I wonder if in our field as well, doing fluid analysis, looking for the monosodium urate crystals is done by only about 10% of rheumatologists. So few of us So could this actually, the dual energy CT or maybe ultrasound, actually replace this in the future? That could well be. And I want to also add to what Rob said very eloquently, that could be that we are going to be doing dual energy CTs of the joints, and then maybe carotids, and then maybe heart, and then maybe, you know, where this is an area that's just starting to have research and studies. So that is very exciting. I mean, again, gout is a disease state, not just joints, and so on. And you know, treatment goes along with that. It's not just the joints. So
I have to add a case. It was supposed to be a study, but it became a case report for us, Rob. I was thinking about what you were saying about ultrasound, and we treated one patient with tophi with pegloticase, knowing from Nicola Dalbeth's studies that tophi have a rind of fibrosis around them. And what we found was that when this patient's tophi were not clinically resolved and were not fully resolved on ultrasound, all the urate was gone out of them. It was like we deflated a balloon. And the DECT was the thing that you could use to say, the problem is no longer the urate that's there. It's you have this fibrotic capsule, and who knows, you know, what will happen with that. And
there's an abstract presented, the number I don't know, but in this meeting, looking at the disappearance of really the what we called icing, and the other group called double contour sign, but we described disappearance of the monosodium urate crystals within 7 months of treatment. And there's a eloquent study, a larger study, showing that what we showed 10 years ago. It's interesting how, you know, people are doing similar studies. And
yeah, that speaks to, that speaks
a little better.
No, I was saying that what you both were saying is what speaks to Dr. Christensen's lecture, you know, her talk and her slides, and she distinguishes in the reasons why we're seeing what we're seeing, and some of the things are kind of merged or blurred on dual energy CT, and they're not as specific and sensitive as we want them to be. Is because of this something called a Compton effect and something called a photoelectric effect, and the difference between how the CT works and how the dual energy CT works, and those are kind of, I guess, the duals, or the Compton effect and the photoelectric effect. While the latter kind of is important for picking up those crystals, and the former is important to pick up the soft tissue, and distinguishing the two from one another, and not kind of confusing, you know, other calcifications or mineralization, and I think from the uric acid crystals specifically. And I think here again, as technology hopefully improves, not only with CT, but maybe even ultrasound, that I think we will hopefully do a better job of figuring out, okay, the difference in distinguishing those two.
Let me, I think that's a good segue, having talked about that and having talked about, mentioned pegloticase too. Let me just turn to another question I wanted to ask both of you, and maybe I'll throw this one out to you, Naomi. There are a lot of abstracts at this meeting basically using DMARDs with pegloticase. And it is definitely for a problem that I've experienced. And I was wondering if you could tell us about that, and we could have a conversation about that.
Sure. So basically, pegloticase is pegylated recombinant mammalian uricase to treat refractory gout. And this approach was used to increase the half-life of the enzyme. And but what happened was that there was development of anti-pegloticase antibodies. And then the question, starting in 2018, was use of immunomodulators, initially pegloticase with methotrexate. Then Dr. Pillinger described in a patient getting azoxystrobin, Imiran, and so on. So I'll just discuss a few of the abstracts I saw, treatment with immunomodulation. So actually, I will start with study that was a multi-center open label study looking at pegloticase in patients that have undergone kidney transplantation. And I thought this was very interesting because these patients post-kidney transplant had very bad gout, and were given pegloticase, and these patients were on 2 or more immunosuppressive drugs due to their transplant. Hence, they were on immunomodulation. And in this study, although a small study of they just started enrolling the PROTECT trial, they saw that the HAC pain score had gone down, and really they didn't see any infusion reactions, which is what we worry with these pegloticase antibody formation. So that was one study that I thought was interesting. And this was something that was discussed yesterday in the Gout lecture. And what do we do with our kidney transplant patients? So that is an interesting option. And that was the abstract 649. Then moving on to abstract 677, this is the MIRROR trial. It was an open label study. Batson, who led this and initially published the data in 2018 using methotrexate. He uses 15 milligrams 4 weeks prior to starting pegloticase, and this was very successful. Initially, the primary outcome was serum urate, proportion of responders during month 6, half a year, with a serum of uric of less than 6 and 80% of the time, and 80% met that primary outcome in this study. And this is double what it was. It was double what it
double the.
It was double what it was in the original trials, which was 42%.
That's.
But it's 14 patients. So this was the MIRROR trial. Mm-hmm. So that was presented and interesting. And I think we feel very comfortable using methotrexate. Interesting that's 4 weeks before. Interesting that's 15 milligrams. Some maybe would use other doses and so on. But I think that's a good place to start. And then there's the triple trial using Imuran or azathioprine in chronic refractory gout. This was abstract 685 and presented by Herb Baraf. And patients are screened for the ACR metabolizing enzyme, thioprine methyltransferase, and they have a dose escalation after 2 weeks, a 24-week study, and they all received the infusion prophylaxis and hydrocortisone, just like in the initial trials. And 12 patients were enrolled to date. They all had bad gout and hantafacious gout. They also did well. These patients with Imuran, one patient had infusion reaction, but really other than that, it looks good. Mm-hmm. Safe and efficacious. People with, yesterday was discussed in one of the meetings, but the people worry about Imuran and gout, but it's really Imuran and allopurinol. Allopurinol interferes with the metabolism of Imuran, increasing the plasma levels of mecarbapyrin, but pegloticase is a totally different treatment and mechanism of
and actually we're not supposed to use allopurinol with pegloticase, so
that is correct. So that is correct, but I'm talking about the Imuran and allopurinol. People are worried using Imuran in gout patients because of allopurinol, but they're not on allopurinol, they're on Imuran and pegloticase, so it's nothing to worry about. I mean, it's a different drug. And then there was the recipe trial, the abstract 952, where patients are now giving mycophenolate, which was the phase 2 double-blind randomized controlled trial. The first author is Dr. Pooja Khanna, and they compare mycophenolate, which they again increase the dosing, and they compare it to placebo. 32 patients receive at least 1 dose of pegloticase. The problem that I found here is that the mycophenolate arm had higher adverse events, more musculoskeletal problems, respiratory problems, and infections. And however, the placebo arm had more infusion reactions, which is expected. The percentage of subjects maintaining the serum urate
suggests mycophenolate.
What did you say? I'm sorry.
Yeah, I'm sorry.
Yeah, and I'm almost done with this. But
no, I was just going to say that sounds like mycophenolate.
Yeah. So Yeah, it definitely does what mycophenolate does, and that's a kind of an unusual side effects or adverse reactions. You know, the issue with using mycophenolate is basically, in my opinion, really clinically, it's not super practical in the sense sometimes insurance companies will deny it. It's not always the easiest medication to get, even though it is generic. It's not as cheap as azathioprine, of course. It seems to maybe work better than azathioprine, at least in the data we have so far. But so far, it seems the most practical reason, even though it's sometimes still not as easy to get as it should be, is methotrexate. And I have not started anybody on pegloticase in the last probably 12 to 18 months, maybe more than that now, on pegloticase without starting them on a DMARD of some sort, whether it's methotrexate or whether it's, you know, stronger immunosuppression like azathioprine or mycophenolate.
Well, I agree with you that methotrexate probably should be the go-to drug. It's the one in some ways, even though it's not the oldest of the three, it's probably the one we're most comfortable with. But of course, some of our gout patients may drink alcohol, and it's good if we have options.
Right. And then this leads me to the last abstract that I'm going to be discussing is 665, although I could discuss a few more. But it's the trends in immunomodulation with pegloticase. So basically, they took a large medical claims database and reviewed the use of pegloticase with an immunomodulator. There were 1.3 billion claims. And they looked at patients that were prescribed methotrexate or Imuran within 60 days before or after receiving the first pegloticase infusion. And what they found is really that since 2018, basically exactly what you described, Rob, we're using more immunomodulation. And if before 1% to 4% were using immunomodulation, now it's up in 2019 to 15% of patients on pegloticase receiving the immunomodulator, mostly within 30 days of starting pegloticase and mostly methotrexate. So this goes with what we just discussed, that methotrexate most commonly used in this database. And I think with the new trials that are going to be coming out in publication, not just abstract form, we're going to be seeing more immunomodulation being used with pegloticase. So
yeah, it just raises questions about, okay, when to start, what dose to start, what to start. Correct. You know, all those questions kind of arise. You know, there's data out there that shows, okay, in some case reports they've started at the same time as pegloticase. Some are starting 2 weeks prior. Some are starting 4 weeks prior. I believe in
what do you do, Rob? What do you do?
I usually, if I can, I usually do 4 weeks. A couple of times it's been shortened because the patient ended up getting infused sooner than I anticipated for whatever reason. And but usually I try to do 4 weeks prior, just to be on the prudent side, just to make sure, okay, if it's methotrexate, it's going to start doing something, it's got time to do it. You know, the recipe trial, I believe, was 2 weeks prior, starting MMF. Correct. So I mean, it's, and I think the mirror trial was 4 weeks prior, I think, too. So I guess it depends, and I think, you know, it's still, the questions are still out there, and
also the 15 milligrams. I use 10 milligrams, but mine is anecdotal. It's not based on any trial, but I feel very comfortable using 10 milligrams. So
yeah, I've been using 20. I've used 15 and 20 depending on the situation, I guess, and how.
Yeah, Well, so this is anecdotal, not supported by trial data. I want to add something important that I know that you know, but
our time is almost up, Naomi, so we'll give you the last word here.
Oh, I'm sorry. No, I don't need the last word, but Lipscott, I'll actually publish data about antibodies and say that over 60% of patients that are over 70 our responders do not develop the antibodies, whereas the younger guys, less than 60, most of them develop antibodies. So, you know, the younger patients getting pegloticase, those are the ones that we have to worry about infusion reaction, while the older patients, not so much. And I maybe the younger, heavier patients, those are the ones that we have to worry about infusion reactions.
So there is so much more that we might talk about. I actually wanted to talk about what diet does now. That seems to be a
So please do,
more confusing question, but our time is up. So on behalf of Dr. Keenan and Dr. Schlesinger and myself, those of you who are watching this, thank you for joining us. And keep looking at Room Now for more gout reports, and have a wonderful meeting.
Thank you so much.
Thank you. Thank you.
Have a good night.
Good
Thank you
you both.
so much. Thank you.